So I was talking with Jill backstage, who I had not met, and I didn't know what content Jill's presentation had. But I almost started laughing when she was like, you've got to ask for the clinical dossier. If there's one question to ask for, it's for the clinical dossier, which is an incredible segue to my talk. So I am Sean, co-founder and CEO of Omada Health. I'm going to share just 20 minutes of a point of view of a conversation that I've been actually having a lot recently, and iterations of it, which is on the incredible power of HR benefits managers in the US healthcare system. And I think there's an extraordinary untapped opportunity. In fact, I can recall 6 or 7 conversations I've had over the last year with deans or academic directors of either medical schools or public health schools, where I've shared, you know what you've got to do is just hook up your students with internships in the benefits space. Seed more medical students over to work in the benefits org of Intel. Find people at Berkeley School of Public Health to go work at the benefits org of eBay. Because I think there is such extraordinary untapped power there. And of course it starts with the financials and really the spend. So self-insured employers spend $605 billion a year on medical care. Now, I know there are some benefits managers in the room. This is a dynamic you're deeply familiar with. For the folks who are more on the clinical side, let me just take 10 seconds and describe how this is the case and what it means to be self-insured. So in insurance design, you actually tend to make money in the risk. So if you're above 1,000 people, more often than not, you're self-insure. And I think you heard from Collective. They, of course, help organizations self-insure in kind of new ways. And really what that means is you still, of course, contract with a health plan. You'll use a Cigna, an Anthem, an Aetna. But what you're buying is primarily 2 things. You are buying their provider network, so their contracts, with Stanford Hospital, they try to negotiate the best rates for you, their contracts with Sutter, et cetera. And you're buying the medical policy. So what you should cover, they'll keep an eye on the regulations, think, oh, well, that new drug or device, does it make sense? So those are the 2 dynamics here. And the spend is so insanely large. You look at the non-out-of-pocket, it's about $2.2 trillion in the U.S. healthcare system. The private side's about $1 billion of that, and about 60% is self-insured employers. Directs a lot of spend, it directs a lot of influence, and actually provides an incredible opportunity to seed innovation, further innovation, allow companies like Omada and Color to flourish as the plan market and the rest of the world starts to catch up. So I think that, there is a huge opportunity starting to happen for HR benefits managers to be tip of the spear. And this is, relevant to this one fun dynamic that always surprised me. There's a great article with Howard Schultz from Starbucks, and he's quoted in sharing that Starbucks buys more healthcare than they buy coffee for their supply chain. So I see some heads nodding from people that have heard that. So, the numbers are astronomical. What it feels like right now to be a self-insured employer is a little bit crazy because there's been such an incredible amount of capital going into companies like Omada, going into companies like Collective, like Color, which is a fabulous thing. And it can be, quite noisy. There are companies in genomics. You just heard of one. There are analytics, pop health, disease management, telemedicine. You name it. There's a flourishing, set of innovations that are happening across the spectrum. So there needs to be, an emphasis on digesting this. So this is a kind of a market map from Mercer describing the incredible palette of things that you might offer to your employees. And, I know lots of benefits managers at self-insured employers, and I'd imagine that at least once a day you get a ping saying, hey, come meet with me. I've got this great new thing you should offer as a benefit to your employees. And it's a lot. It can be a ton to take in. And, I think that the innovation here is great. I love that the market is flourishing, that there's new ideas being put up. I think that employers can direct innovation and really transform tip-of-the-spear healthcare in the U.S. By really asking for the following. And this speaks to the comment that, Jill made at the end, ask for the clinical dossier. I'm going to talk through 5 categories where if you are a benefits manager, I would encourage you to ask the partner or really just poke at a little bit further. So the first is just the evidence base. So, why does this exist? What is the evidence base upon which the solution was designed? And what's the clinical reason behind it? The second, okay, great. So you have a why. Do you have actual efficacy with your solution, both in the clinical and real world setting? Given your data, if you have the ability to see outcomes, can you go ahead and just charge on it? We are in a shift from volume to value across other areas in the healthcare system. Why shouldn't that be the case here as well? And then how are you using those data to personalize? And then last, how are you integrating with the real medical community with existing benefits, not pretending that you can completely circumvent the healthcare system? You really do have to acknowledge that, yes, you may be working with the employer to get employees, signed up, interested in trying your solution, but you really do need to think of what bridges, if any, need to be built to the provider side. So, making sure that you're not forgetting about those aspects. So let's start with the evidence base. I think there are many examples of this. For Omada's case, we got really excited about the evidence base in diabetes. It's a continuum. As you gain weight, in the type 2 space, you tend to get some high blood sugars. There's a range where sometimes it'll be called borderline diabetes, pre-diabetes, but the warning signs are there. And those folks readily convert into type 2 diabetes. So, huge crisis. We have, unfortunately, about a third of the country at risk for diabetes and barreling toward this cliff that is type 2. For the first time in global human history, obesity-related chronic disease and preventable chronic disease is killing more people than infectious disease. That's kind of a very scary reality for not just the U.S. But the globe writ large. Yet the silver lining here is it's preventable, and there are things you can do. There's an extraordinary body of evidence that shows if you intervene in the right way through a very high-touch program and intervention, you can dramatically reduce the risk of progression through chronic disease. In the diabetes space, there's a huge trial called the Diabetes Prevention Program, where they took 3,000 people, they randomized them, they brought 1,000 through an in-person high-touch program. That reduced the risk of progressing to diabetes more than a medicine. They tried metformin, and far more than handing someone the curriculum and saying, have at it on your own, which if you look at the control arm of every clinical study in the space, does not get you a result. So, amazing body of evidence. Clinical guidelines have evolved to really support this intervention. This momentum continues, yet the challenge has always been the ability to scale. So we looked at this platform of evidence as a foundation for a company, and really before Omada, gold standard was this. It was a group-based intervention or one-to-one intervention, in person, where you'd get to know the person, meet with them over multiple periods of time, set up clear goals, accountability, social support, make it so that someone doesn't feel alone, bring someone through a very behaviorally forward lifestyle intervention. Of course, that has challenges with scale, flexibility, accessibility, monitoring, analytics, and that's where we saw the opportunity in really bringing this to life. And additionally, where guidelines have emerged is that folks who are obese, overweight, with these cardiovascular risk factors, prediabetes, hypertension, high cholesterol, should be referred in. So what we hope to do is change the fact that the evidence is there, but there's inherent limitations in scaling it to, great, you can drop this in and deploy it nationally, across the entire U.S. And so now at Omada, we've enrolled over 120,000 participants into our program, working all 50 states. We actually become the biggest provider of these interventions in the entire country. But it's not enough to just say it. The second thing that I always encourage HR benefits managers to ask for is, great, you have good clinical reasoning for what you do. Now, where's your evidence? Where's your demonstrated efficacy? No, don't point to your competitor's trial. Don't point to that meta review that you've seen. Like, where is your solution's data? Ideally in the peer-reviewed literature, well, definitely in the peer-reviewed literature, but also ideally in real-world settings. So this doesn't come easy for digital health entrepreneurs, but it needs to happen. One of the very first things we did was publish data. So we ran a cohort study, looked at hemoglobin A1C, looked at weight loss over a period of a year, published 2-year data. We continue to publish papers. We actually now have 9 peer-reviewed publications, and we plan out a clinical development map, like you might if you are a therapeutics company. So I think this is mission critical. The thing that I'm really excited by is 6.5 years ago when we started Omada, I had very few moments of interacting with a technology entrepreneur wanting to enter healthcare where they'd come to be like, hey, I heard you should publish. Almost never happened. Now that's happening so much more frequently. And you have companies like Evidation that help you think about how you might publish your results. I just talked to the founder of a company called TrialSpark. They help design research studies. They're really nimble. They want to work more in the digital health space to allow companies that are burgeoning to publish their outcomes. But I think that's necessary. I don't think there's a shortcut there. Not just one publication, you've got to do multiple. I mean, we've looked at Omada's impact in different demographics. This is a publication in seniors and Medicare for us. We ran this publication because we knew that Medicare is very actively working towards shaping a benefit for diabetes prevention programs, and we needed to make sure these data were out in the world, because without it, digital health is an underdog and digital delivery of these programs is an underdog. So you really have to think about your market needs when you publish. In terms of real world data, there are other things that are important to measure, and value can be determined and derived at various points. So, of course, the clinical value is the number one compass that a digital healthcare company should look toward. There are other values at the organizational level that can be shown, and this can be telling as well, where, when you're evaluating a digital health vendor share, hey, you know what, have you asked people that have tried it if it increased the appreciation of their employer? I think this is a good measure, and we've started surveying this, and it always hovers in the upper 70s, low 80s of people that share, being offered Omada actually, made me appreciate my employer more. And I feel kind of a greater sense of affinity and loyalty to my organization. So this is kind of a measure that's really, well, great, you're delivering a clinical impact. What was the experience like? Is this something that you deploy and people kind of come up with noise, or is this something you deploy and you get thank you notes for, which I think is mission critical? And then I think you just got to continue as a digital health company. And you should ask, well, great, you've got these publications. What's your plan for more? What are you thinking about? Could we work together on some? I think that really helps separate, some of the noise there. I always encourage that. I think we're in a neat moment with digital health where, because of the data that you can collect from these interventions, you can create new business models. And, it's funny, when I started the company, we were looking at our data, we have this cellular scale, we send it to participants, the data's coming back. I mean, we're seeing the real-time outcomes, and we're seeing that it's working, and we just started to say, well, we should just charge on those outcomes. I mean, the unit of value is that outcome. Why don't we charge on that? And, I didn't realize how extensive the PEPM business model was, but I think when you can avoid it, that's the route to go. When you can charge for the specific outcome you're working to get, I think both organizations are a bit more aligned. Because sometimes what can happen in a PEPM structure is you're slightly disincentivized for more people using it, because that narrows your margin as an organization, which doesn't make sense for either party. I mean, you really want to create a world where the partner is incentivized to have the biggest impact possible, and then you're only paying if it happens. What we do at Omada is we have an enrollment fee. We bill on that. We actually file through claims, which I'll tell you about in a second. And then all of our profits are derived for outcomes on a per % watt loss basis. So if we do better with someone, our fees are higher, and that ensures that our fees are always proportionate to the impact we're getting. So now, what I want to say is this isn't always possible in every area. You really do have to have the data points near enough and align on that as the unit of value to be able to charge on it. But when that is the case, I think it's an amazing thing. And, the neat thing, too, internally at Omada, what it's created is a culture of constantly thinking about the product in a different way. Because what we can do is think, oh, you know what? If we've got, Frank at 4% and we can get Frank to 5%, we know the financial value of that. And that allows us to very quickly determine, well, all right, let's try this intervention. Maybe we'll invest $100 in this person to try something new based on what they're struggling, and we'll look out over time to see if that was an ROI positive intervention for us. And I think this should continue, across the spectrum. Another area, in addition to a business model that I think digital health companies should be held to, and this is happening, in many areas, is just personalization at scale. I think digital allows for the sort of measurement, tailoring that you could never have. Definitely in the behavioral medicine space. I mean, you just can't sit on as a fly on the wall in every behavioral medicine intervention. It's very hard to change and tune and tailor. Sometimes I call this the ether dome moment for behavioral medicine, in that prior to anesthesia, which was created in Massachusetts General's ether dome, prior to that, it was quite difficult to do surgery. You were very limited to what you can do. I think prior to digital and this incredible surge in how people are using technologies, behavioral medicine, is tough to tune and administer. And, I always call this, the symphony. I think in our space, I talk a lot about the single instrument fallacy, which is, it's very difficult to mail someone a scale and put up a chart and, get an outcome. Can't just get them a tracker and get an outcome. Can't just hook them up with a coach, put them in an online message board, get in the content, set a goal. You really need a concert. And digital allows you to play the instruments in a different way over a different period of time, which leads to really the summary of all this, which is delivering the right intervention at the right time for the right participant. And we often call that precision prevention. I think a fun analogy in our world that we're starting to see more and more and more in the digital space, where a digital experience, even if it includes traditional diagnostics or traditional therapeutics, it can actually further an outcome. And one I love to make is just comparing traditional treatment with a digital treatment, if you will, a digital program designed to deliver a clinical result. So if you think of a pill or a medicine, right, you've got the chemistry on the inside. On the way in, you've got the prescription, who's it right for, you've got the dosage, and then you've got the coding. So, the active ingredient, of course, is the chemistry, right? What works there. In a digital space, the active ingredient is, the foundational clinical evidence and the discrete elements that are helping create that outcome. So it depends on the intervention, but it could be, the curriculum, the content, the coaching, the connected devices that are shaped in the right way you're using the data, the peer pressures, the social relationships you're creating. Like that is your, I guess, active ingredient, if you will. And then the coding is really the user experience and the design and the way, it's the way that the pill tastes, right? The design experience that allows you to want to do the program, not feel like you have to. So I think, I always like to describe that as, the coding. The targeting is really who's eligible. Who do you actually try to reach out to? What's your approach for trying to find the people that would most benefit for this intervention and reach out to them? And then you tailor based on people's behaviors in the program, right? In the same way as you would tailor the dose of the medicine according to the person's size, maybe their reaction, their side effects. You tailor this intervention based on the data. And you use strong data science on both of those to figure out how you tune who you target and tune who you tailor. So I think that we're seeing more of these metaphors in the digital space toward the traditional space, which allows us to ask these same sorts of questions and ask for a clinical dossier, which I think is a really fun world that we're currently in, and allows for really how we view tuning the program for various clinical indications. It's almost a dynamic of personalization, where someone could come into the Omada program, perhaps they have prediabetes, they also have hypertension. We're building out modularity so we can tune that program for them and really treat their clinical status and the goal you want to achieve as an aspect of this personalization to get to a better outcome. Of course, last but not least, integration. So this is deeply important. I think a solution that's invested heavily in integrating with existing infrastructure is one that's easier to deploy, is less headache, there's less to manage, and that's incredibly important. As strange as it sounds, Omada actually more often than not contracts as a provider under a health plan, even when we're working in the service of an employer organization. And we worked for many, many years to get the American Medical Association to create a CPT code. They actually made a digital specific code for our category of intervention. We contract as a provider. We shape the papers to make that work because, of course, we're a digital provider. It's a bit strange. And then we file claims. And we found that this makes it easier on everyone. We're billing on outcomes. We're only filing a claim, of course, when someone comes into the program. It's treated as a medical expenditure. That you don't have to contract directly with Omada if you don't want to. We can work under your plan or your TPA. And we found that makes it a whole lot easier for our partners. Additionally, whenever possible, if there's the ability to do it, we love to make sure that we're in close touch with the real healthcare system. If an employer has an on-site clinic, we want to make sure that we train those folks in knowing how to refer, who they should refer. Whenever possible, when people want to be kept in the loop, we want to share back on here's the results we're seeing. We do work in the provider space, and through that, we've built out a whole suite of tools and outreach tools and care pathways to really align on that. So we'll train care teams. We'll work to use population health tools. Whenever there is the chance to do that, we really do try to build these bridges. And in some communities where we have a very dense employer-customer penetration. We'll look at, okay, well, what providers are in there? How might we say hi to them to see if there's some synergy there, so we catch more people and make sure that they're kept in the loop, which I think is critically important. And companies that go down this route, I think are the companies that stand to have the broadest health impact, writ large. I think a piece of this is, of course, maintaining medical collaborations, presenting at conferences, staying up to speed on the science. Companies need to continue to do that. And you should ask for how you engage with the clinical community and integrate with the clinical community, even outside of what we might do together at the employer-employee level. And I think, through those, if you go through those list of questions, HR benefits managers can really become these superheroes, because what happens is the tools that get adopted that are aligned with all of those begin to propagate further. And, employers have the ability to make, more innovative decisions. You can look at something evaluated in those measures and give it a go and try it, in ways that, you might be years ahead of what would happen at large scale, trying to get, Medicare to pay for something or really get it adopted holistically across the entire ecosystem. And employers can help push and bring interventions along that way. And we've experienced this, very early on, some of our employer partners. In fact, Stanford Hospital was one of our very first customers for their employees as a benefit, and they remain a customer today. Those individuals help say, well, cool, great, you should meet my health plan. Maybe we can build through the plan. And that opens up other opportunities and creates kind of a cycle upon which a digital healthcare company that aligns with those pillars can grow. So, always when I, meet with benefits leaders across the country, what I always share is, wow, you have so much power to change healthcare. And, I have talked to so many of my friends who are either in school or friends that are thinking about, getting MBHs. I'm like, you should just go say hi to benefits org for a bit, because the amount of spend that self-insured employers control and the agency that they can have on improving the health of the country is absolutely enormous. So, I guess my call to arms here is become a superhero and let me know if, I can help you do that. So thank you so much.